Well, welcome to today's clinical teaching session, which is on reasonable adjustments and how that applies to people with a learning disability and or autism. We wanted to start off by just talking about the law which underpins reasonable adjustments, and that is the Equality Act 2010. And this is a law which protects people against discrimination. It is illegal to discriminate against people not only in the workplace but in wider society. And there are 9 protected characteristics which the law describes. And these are race and ethnicity, disability, marriage and civil partnership, that applies to the workplace, pregnancy and maternity, gender reassignment, and also gender, sexual orientation, age and religion. So it is illegal to discriminate against an individual on the basis of any of those protected characteristics. Ignorance is no defence. You can deliberately discriminate against somebody because they've had a gender reassignment surgery, and that's illegal. But it's also illegal to discriminate by accident. So that's the legal basis. I'll pass you on to Katie.
So today we're just going to be looking at the disability element of the Equality Act, because that's what learning disability and autism comes under that group. And what that means is that that is protected under the Equality Act, so it's important to know what law underpins that. And you can see that our campaign from the LD service is pretty much in line with the national agenda, which is equality and inclusion. And I think sometimes the phrase equality is quite misleading because we're not asking for equal, we're asking for reasonable adjustments so that our patients can have the same outcomes as everybody else. So it's not necessarily that they have equal, it's more fair. So bearing that in mind, we just need to consider as well what CQC and other legislations say about reasonable adjustments in the Equality Act. In your delegate packs you can see, as some of you might be aware, I'm a fan of the Mental Health Act Code of Practice, and there is a section in there that talks about the Equality Act and reasonable adjustments. I have printed it off for you. And basically what the Code of Practice says is that we must make reasonable steps to avoid putting a person with disability, so that's people with autism or learning disability, at disadvantage compared to people who are not disabled. So in effect what they're saying is that we should take a person-centred approach in mental health settings in order to make those reasonable adjustments. Now, in the mental health setting, those types of things would be a communication passport, or it might be a health action plan or a PBS plan where a patient can document their preferences, their where a patient can document their wishes, their preferences, how they choose to be cared for, how they can be cared for should they become unwell. And I suppose the message today really is that patients are part of the MDT. That's really important, that their views are listened to and documented. And not only the patient, but also it is imperative that the family members are listened to as well.
When you question the system protects itself, and unfortunately the coroner is part of that system.
I want to make it clear that Oliver's voice was not heard when he was alive. He was not listened to. We were not listened to as his parents that knew him best. And even in his death, he has not been listened to. He's been totally ignored.
On the 25th, there we go, 25th, antipsychotic medication, allergies, don't give them it.
I found that heartbreaking to see that.
So 24th, 25th, And then, you know, things started to go wrong thereafter.
They misunderstood his autism. They were not willing in any way, shape or form to try and understand how autism affected him, how it presented itself. They were just too quick to label it as a psychosis.
We accept the coroner's narrative conclusion and will find learning from Oliver's case. We are absolutely committed to improving care for all people with learning disabilities.
Hello, hi, and thank you everybody for coming today. I'm Oliver's mum, and I'm the proud mum of this wonderful young boy, and I'm going to tell you a little bit about Oliver and his story. So from the moment Oliver was born, we knew that he was special, and our love for him was overwhelming. Oliver was born premature and developed meningitis at 3 weeks of age. He was very ill, and we were told that they did not expect him to survive. However, Oliver began to recover. Everybody who came into contact with Oliver warmed to him, and they could not resist spending time with this baby. Sadly, Oliver developed a second episode of meningitis, and he was incredibly ill again. But Oliver, the way he was, amazingly, against all the odds and many months of hospital treatment, Oliver's strength and determination shone through, and he survived once again. And always with that beautiful smile that you can see up there, that everybody was drawn to. As a result of an infarction, so basically Oliver had had a stroke as a result of the meningitis, Oliver was left with mild cerebral palsy, focal epilepsy, and later on a diagnosis of high functioning of autism. However, Oliver's disabilities didn't hold him back. He had a can-do attitude, and he simply amazed everybody with his achievements. He played for the South and North West Centre of Excellence England development football squads. He was a registered athlete with the power of 10, and Oliver was actually ranked 3rd best in the country for athletics. Oliver was a member of Team Bath, and he was being trained to become a Paralympian. Oliver was a natural leader and became a prefect and was chair of the school council, and again was selected once he reached college. He attained several GCSE and BTEC examinations, and he went on to attend National Star College. Now, their opinions of Oliver were very complimentary, and he was often mistaken to be a member of staff. They talked about how friendly he was, how kind, and supporting other students that were far less able than himself. His wicked sense of humour and the aspirations that they had for him for starting a sports course at a local ski centre. Oliver brought so much happiness and fun to our lives, and he always saw the best in everything and taught us all how to look at things differently. Oliver never failed to light up a room with the sound of his laughter, and he wanted to make everybody happy, and he did his best to achieve that. Despite his limitations, he never complained or ever asked, "Why me?" And he accepted everything, and always with that beautiful smile. His courage and enthusiasm was inspirational. We were told by his neurologist that Oliver had a full life expectancy and that he would live an independent life with a minimum amount of support. In October 15, Oliver was admitted to Bristol Children's Hospital, having what we, his parents, and college staff recognised to be simple partial seizures. Now, rightly so, these seizures caused Oliver to be anxious, agitated, confused, and frightened. After several weeks of tests, Oliver was discharged home, and he was given sertraline, an antidepressant medication to treat his anxiety. Now, we were quite shocked at this because Oliver was not depressed at all. Now, once this medication was increased, it caused a change to Oliver's mood, and his seizures increased greatly. and he was admitted back to the same hospital in December 15. But this time he was given antipsychotic medications. The doctors were misunderstanding Oliver's autistic behaviours to be an ictal psychosis, his normal autistic obsessions to be delusional behaviours. The effect on Oliver was catastrophic. Oliver's seizure threshold and anxiety deteriorated, and he was eventually held against his will under the Mental Health Act on a Section 2. Excuse me. We challenged this on numerous occasions, stating that we felt that the drugs were causing the changes to Oliver's mood and seizures. A psychiatric bed could not be found, and doctors decided to listen to us, and they removed all antipsychotic medication. And within days, Oliver's mood and seizure activity improved, and he was discharged back home into our care. A community psychiatrist wrote that Oliver was sensitive to antipsychotic and benzodiazepine medicines. In April 16, Oliver was readmitted back to the same hospital, again having simple partial seizures. And once again, the pattern was the same. He was anxious, scared, frightened, confused. And sadly again, Oliver was given antipsychotic medications, one of more of which caused a serious side effect called oculogenic crisis. And he was left like that for several hours because the doctors first believed it was behavioural. After 4 hours, he was given procyclidine medication to counteract the effects of haloperidol. Again, Oliver's mood changed significantly. He was hallucinating, having up to 30 seizures a day, which was something that we'd never seen happen. He had problems urinating. He had extreme high blood pressure readings. He was sweating, all of which were linked to the medications. We strongly believed the drugs were the cause of the decline in Oliver's mood, and it was obvious to us that the doctors and nurses had little to no understanding of autism and how autistic behaviours could present in a person with ongoing seizures. When in seizure, Oliver was always fully conscious, and because he had no control of the seizures, they caused him to be frustrated and scared. At my request, Oliver was transferred to a specialist adult hospital, who I thought would have understood Oliver's epilepsy better. Oliver had been provided with a letter stating his reactions, his previous reactions to all the medications he'd been on. But sadly, the extra use of physical restraints was increased, with up to 8 staff being involved at a time. Oliver was suddenly not allowed any privacy, whereas in the children's hospital, he had full privacy. He had 3 staff sat around his bed, and he was kept in a darkened room. Oliver was extremely frightened, and he told me just how scared the staff was making him feel. Remember, this was a person that never ever questioned or ever said once, "Why me?" And for the first time in his life, he told me how scared he was. And once again, he was given lots of different antipsychotic medications. And consequently, Oliver was detained again against his will on a Section 2, this time transferred to a mental health unit. However, once he got to this unit, the different approach from skilled staff allowed Oliver to improve within days. They were using reasonable adjustments. The words from the staff, including doctors, senior doctors in this unit, were that Oliver was not psychotic, he wasn't mentally ill, and that his placement was a total misuse of the Mental Health Act. The doctors reduced all antipsychotic medications, and literally within days, Oliver was discharged back home into our care again, but this time under the supervision of the Community Learning Disability team, with a letter once again saying how sensitive he was to all antipsychotics and benzodiazepines. The Learning Disability team were very supportive, and they specialised in people with autism and learning difficulties. The community consultant in psychiatry wrote, after his assessment of Oliver in the community, that his opinion was that Oliver was not psychotic, he was not mentally ill, He believed that Oliver's behaviours were a result of autism, mild learning difficulties, and an environment that was not adapted to meet his needs. So that was written down. Sadly, in October 16, Oliver had a cluster of seizures, simple partial seizures, fully conscious, but it's a seizure. And he was admitted to Southmead Hospital. Oliver told ambulance staff and also the doctors in A&E not to give him antipsychotic medications, and he gave a good reason why. He said to them, "They mess with my brain and they make my eyes go up." He was referring to oculogenic crisis. And he was reassured by the doctors that they had no intention of using those medications. We gave the doctors a folder of supporting letters stating Oliver's previous reactions to all antipsychotic medications. And this was subsequently written in bold red ink on Oliver's medical care charts, that he was intolerant to all antipsychotic medications. Oliver was intubated so that they could gain control of the seizures and they could do an MRI scan. The safeguarding officer was consulted on how to manage Oliver's anxiety when sedation was reduced. And his advice to the doctors was a non-pharmaceutical approach. If needed, use soft handcuffs, because they were worried that when Oliver woke up, he wouldn't be aware that he had tubes down his throat. So by this time, he'd developed pneumonia, and they were scared he would try to extract those tubes. And we were reassured that we should be there when Oliver was woken up, so that we would be a familiar face and we would be able to reassure him, being his parents who knew him best. We were told that just about nearly everybody in the community and in our society, everybody waking up from sedation would be anxious and agitated, because that's just what it is. Sadly, this advice was not listened to. Sedation was reduced without our presence. And according to staff, Oliver became anxious, quite rightly so. He would have felt scared, waking up to find the tubes in his throat and in unfamiliar surroundings without familiar faces. Sadly, sedation was increased. And we were consulted by a neuropsychiatrist who had met Oliver for 2 10-minute appointments in the community. And she asked us about giving Oliver an antipsychotic. We made it very clear about Oliver's previous reactions to this type of medication, supported by those letters that I always had with me. And we made it very clear to her that she did not have our permission, but more importantly, she did not have Oliver's permission to administer antipsychotic medications. Despite this, Oliver was given antipsychotic medications that evening. We weren't aware of it. He was given olanzapine, and it was done without our knowledge. When we found out the next day, we told the doctors and nurses that they didn't have our permission, and they absolutely did not have Oliver's permission to administer that drug. Over the next few days, Oliver developed a temperature of over 42 degrees. And because doctors said his liver function was elevated, he was not given any medication to counteract that temperature. And he was just given a blow-up mattress, something that looks like a lilo that you'll find on a beach, filled with cold air. It was totally ineffective. Doctors could not understand the decline in Oliver's condition, and they sent him for a scan of his liver and lungs. Unfortunately, it was several more days before they scanned his brain. And what they found was, words I will never forget, it was so badly swollen, it was bulging out the base of his skull. We were told that Oliver had neuroleptic malignant syndrome, a rare but serious side effect of antipsychotic medications. A week later, the decision was made to turn Oliver's life support machines off, and Oliver passed away several days later on the 11th of November 16, Armistice Day, which is very poignant to us as a family because we are a military family, and Oliver was a military child. A life wasted due to doctors not communicating effectively with family and practitioners who knew him well and who were in daily contact with the hospital. We believed the doctors were arrogant, and we believed they were ignorant, and we believed And we think that they believed they knew better than Oliver. They knew Oliver better than ourselves as parents. They didn't consult wider when there was ample of time to do so. There was plenty of opportunities. We have since been told by the doctor during Oliver's inquest, who administered the antipsychotic drug, that she would have given it regardless of our wishes, as she believed it was in Oliver's best interests. And she said she would do the same thing again, given the same situation, knowing that Oliver is dead. Now, we understand that many people receive the medications that Oliver was given, often for managing a mental health condition, and they do so without suffering any of the effects that Oliver had. In Oliver's case, we had clear understanding that he was sensitive to these medications, and we believe strongly that they should never have been prescribed. We believe that Oliver's death was very preventable. We believe that Oliver was given excessive drugs due to medical staff not understanding autism impacted by seizure activity. They didn't ever try to adapt the environment to meet his needs. They made no reasonable adjustments, but used excessive restraint methods. They failed to make any communication with community-based professionals that knew Oliver best and who were working with him on a daily basis. We're talking about consultant psychiatrists here, but they didn't consult wider. If the guidelines and principles from the NHS England Stopping the Overmedication of People who Have Learning Disabilities project had have been followed, with healthcare professionals being able to listen to family and specialist colleagues, then we firmly believe that Oliver would still be here today. We believe that Oliver's premature death should be in the public interest, and we challenge every one of you today, when working with your patients, to ask people with a learning disability, autism or both, their families and carers, for their opinion and concerns about their treatment. Listen to all involved and show respect for their opinions and concerns. Do something about it and work in partnership with your patients and with your patients' families. Specifically, as people who provide specialist care in learning disability and autism, put those people at the heart of all your decision making. Respect their point of view. Don't make decisions without them. Enable them to understand complex decisions in a way that is relevant to all and provide information and explanation. Liaise with healthcare colleagues in general hospitals and the community and raise awareness and understanding of learning disability, autism and the principles of STOMP. Do everything in your power to prevent a story like Oliver's having to be told again. Now, MenCap, there are lots of campaigns happening at the moment, as I've mentioned. I've mentioned STOMP, I've mentioned Ask, Listen, Do, I've mentioned challenging behaviour. That is not the patient's challenging behaviour, by the way. That is your behaviour that challenges the person in crisis. And then, of course, MenCap have Treat Me Well, which is all about looking at the person and doing the right thing, treating them in the right way. So can I just talk a little bit about what reasonable adjustments are? Jake, wherever you are, can you come up? Where is he? Don't touch that. Right, Jake, today what I want you to do, right, I want you to go into my classroom. I'm a teacher. You are to go in today and teach my class of 5-year-olds. I want you to go in and talk about graphemes, phonemes. I want you to talk about digraphs, trigraphs. I want you to do oral blending, segmenting, partitioning. Okay, got that? How do you feel?
Uncomfortable.
What am I doing? What's wrong?
You're quite close.
Anything else?
You stood over me.
Okay. Did you understand what I said?
No.
Okay. Okay. Jake, are you okay?
Yep.
Okay. What I want you to do today is basically, can you go into my classroom of 5-year-olds, and I just basically want you to teach them how to read. So we're going to be looking at phonemes, which is basically letters. I want you to look at digraphs. So that's basically just 2 letters that make one sound. The trigraphs, we're looking at 3 letters that make one sound, so like IGH, I. Okay? I want you to break that word up for them. And while you're at it, you've got to, the oral blending is actually what they hear to what comes out of their mouth. Okay, how does that feel now?
Much better.
What have I done that's different?
Come down to my level and spoke in a way that I understand.
Has that had a different outcome for you?
Yep.
When I was in your face, Jake, can I just ask you, I'm going to come back up again. Do you have a learning disability?
No.
Do you have autism?
No.
Are you in crisis?
No.
If you had those conditions and I came to you just then, if I'd not made that reasonable adjustment, what do you think you might have done?
Maybe lashed out, got anxious.
And that's where we're going wrong, because quite a lot of the time this is happening. We're not making our reasonable adjustments, and a lot of practitioners are reaching for chemical restraint. Okay, thank you, Jake.
Just wanted to clarify that several senior clinicians had said that Oliver did not have a mental illness and should not receive antipsychotic medication. But he got antipsychotic medication, which killed him. So what historians try to do is put themselves into the headset of the people of the time to try to better understand. And we need to do exactly the same thing with people with, who are on the autistic spectrum, because they are different. They're not ill, they can't change because they're hardwired that way. And unless we take the time to try to understand what it's like, insofar as we can, we will consistently get them wrong and misjudge them and misinterpret their actions. The lessons that we've all learned about how to treat people with mental illness and personality disorder very largely don't apply. We have to adjust because they can't. I found that talk extremely powerful. Please just have a think about what that meant and what it has meant to the family, let alone to Oliver. And try to think about what autism actually means. You can't get it off the page. Reading about lack of theory of mind doesn't mean anything. You have to sit with people and try to understand what their circumstances are, what their feelings and beliefs are. So once again, thank you very much, Paula. That was absolutely fantastic. Thank you. Yeah. You want that, don't you?
Thank you. I'm sure everybody's got lots of questions for Paula, but I just thought I'd start off by doing some questions for the benefit of the audience, if that's all right, Paula.
Yes.
So, as some people might be aware, you've been involved in a campaign petitioning to the Parliament. I just wondered if you'd be able to explain to people and give people an update on that.
So, after Oliver had died, obviously we know he died as a result of neuroleptic malignant syndrome. But I sat down one day and I kept thinking, well, what was the catalyst of Oliver's death? Where did it all go wrong? Because, you know, Oliver wasn't challenging. He didn't have challenging behaviour. So I thought about it, and I just thought, well, actually, it was because the doctors didn't understand his autism. And it was very high-functioning autism and his mild learning disabilities, and that became apparent during the inquest. They just didn't understand autism. And I thought about it, and I thought, well, actually, well, first and foremost, it's cost Oliver his life. This is not good for patient safety. But also, it's not fair for our doctors either, and our nurses and all people that work with, you know, people with autism and or learning difficulties. It's not fair. You wouldn't ask a mechanic to go and fix a car if they weren't trained in engineering. So why on earth do we ask our medics, and you must yourself see challenging behaviours, you need training in that. Why do we suddenly expect a doctor or a nurse to be able to look after a patient in a crisis, having an autistic meltdown, if they don't have the skills to do that. So I thought, no, that's not acceptable. It's not acceptable to the patient. It's not acceptable to our medics. So I decided to start the parliamentary petition. I'd never done Twitter before, and I've learned how to do Twitter very well. I've now got 5,000 followers. And within, I only started the petition the middle of June, and just a few months down the line, I'd gathered 50,000 signatures. It was hard work. And then suddenly I was gaining attention from the likes of Caroline Dinenage, Jane Cummings, Chief Executive of Nursing, Ray James, John Trevane, so lots of names, Dominic Slowey, just Rohit Shankar, loads of names. And I was invited to go into Parliament to discuss Oliver's petition, but also to meet Jane Cummings. Now, this is fantastic, but I'm also aware that the Leader Report, and for those of you who don't know what the Leader Report is, that is the Learning Disability Mortality Review. So this was about to be announced in Parliament. Now, given that Oliver's death and the things around that, it was all timely. So I had this meeting with Caroline Dinenage and Jane Cummings, and it was incredibly positive, and I was told that mandatory training has been approved. At the moment, it will be on 3 tiers. And the first tier is that everybody who works within the NHS, everybody, that includes cleaners, will have a level of training in autism and learning disability awareness. Then we have 2 other tiers. And those tiers are about to go into consultancy. So there's lots of people going to be coming together. Now, those tiers will be aimed at doctors and nurses. Now, my brief to Caroline Dinenage and to Jane Cummings were, this training must be face-to-face. It must be looking at the undergraduate doctors and nurses. The doctors need to play a huge role in this, because at the end of the day, they are the decision makers. They are the ones that are in charge of the patients. That training needs to be effective training, and it really needs to be able to support our doctors and, of course, our nurses in being able to support those patients. So the petition has been successful.
So is there any opportunity for you to influence what's on the curriculum, what the course content will be?
So just this morning I've had an email from Gareth, and please forgive me, Gareth, I can't remember your surname. So he works with Caroline Dinenage, and they've asked me to be part of that consultancy. So I will be able to look at it and play a part on what that training will look like.
And are we able to kind of influence that today, do you think? Do you think we'd be able to?
I think so, because the training, we've got to remember, the training is for patients who have autism and or learning disabilities, but in actual fact, this training is for you guys. It's to enable you to be the best practitioners that you can be. And what I'd like to ask all of you is, what could this mandatory training look like for yourselves in your establishment? We're working within this field here today. What does reasonable adjustments look like for you? And I know, can we just give you 5 minutes to talk amongst yourselves to discuss that? So what would you like the mandatory training to include? What would it look like? What do reasonable adjustments, what do you think they are? What do they look like? And how can I take this forward to the people that I meet?
So everybody with autism is actually unique, and they might have a whole raft of different problems, from a praxis to who knows what. But who are you going to get that insight from?
I think it's from the person. So if that person is able to verbalise, or you need an advocate to advocate on their behalf.
They might be able to, but and that's where I've learnt most of mine from. But of course, they're normal. You're not normal. You're neurotypical. They're on the spectrum. That is their normality. They don't know anything else. Why are you shouting so loudly? Do you know what I mean? They can't tell you about the disease they've got because they haven't got one. They just live in this world. But I think you're absolutely right, and I think it's getting testimony, isn't it, an experience from carers and parents, but also sometimes just actually sitting with and interacting with somebody with autism, or mild with learning disabilities as well, of course, but I'm talking about autism, is fascinating because you can learn, you can see what works, you can get a feeling for things. And some of our staff here, of course, have spent years doing just that. So yeah. So I'm going to put kind of experiential work. Will that cover it? That's great.
From an applied tier 3 level mandatory training for doctors, I think the Royal College of Psychiatrists in particular, would need to perhaps develop a training tool for doing a mental state examination in somebody who has autism.
That's really interesting, yeah.
In order to be able to determine whether or not the judgments we use in deciding, is this person psychotic, is this person delusional, is informed by everything that we ought to know about an autistic individual's mental state that's normal, so that we can then decide if for an autistic person the presentation is in fact normal, or like anybody else abnormal because they also have a mental illness or whatever it is.
That's a really fascinating. Can you put that down? Did you get all that? Yeah. Good. That's a really interesting, because of course I was talking earlier when I first started, one of my first autistic patients who was on a 30-bedded mental illness unit was detained under the Act, but the Act didn't recognise autism, so he had to be either a psychopath or learning disabled, and he was neither, because there just was no understanding at all of it. And lots of patients, and we see them here, are misdiagnosed as PD or psychotic. We also have a patient who is psychotic and autistic, and now happily he's just autistic and much better for it, because he had beliefs which were to do with his autism, but they'd become delusional in intensity and he was acting upon them. So yeah, that's a really interesting idea. I don't know how you'd go about doing that, but that's a fascinating idea.
I was just going to say, what you've just highlighted there is very, very relevant. In actual fact, you know, you just mentioned about the difference between what is a normal behaviour for somebody with autism and what is the behaviour, you know, what's the differentiation between normal and mental health. And that's what was happening to Oliver, in that when he was in a crisis, so he was impacted by seizure activity, you would see the autistic behaviours. So Oliver was a game blogger. Autism does not necessarily mean that you're not bright. Oliver was incredibly bright. And he started talking about this gamer, phase temper, and he talked about it over and over again. Now, because Oliver wasn't listened to, and because we weren't listened to, the doctors in charge of him thought it was delusional behaviour. And they also labelled ictopsychosis. But in actual fact, if they'd listened to us and listened to Salim Razak in the community, he is quite a prolific psychiatrist in learning disability, they would have seen that this was normal behaviour for Oliver. And I think you've raised a very, very important point. Thank you.
Really important to have those passports. So it's a communication passport, it might be a hospital passport, it might be a life story. So like your son, for instance, hopefully that could have been passed on better than it was and prevented an awful tragedy.
Oliver did have a hospital passport, and for those of you that might not know what one of those are, a hospital passport is a document that details things that affect, so previous reactions to medications, what will heighten a patient's behaviour, what de-escalates their likes, dislikes. It's information that you would like passed on that will enable you to have a better outcome. So we did provide a hospital passport. Sadly, it was just put away in a drawer. It wasn't even looked at. As parents, we couldn't have done anything more than what we did do. We are parents that were very much on the ball. We couldn't have done any better anymore. And as I said, Dr. Mohan had actually said during the inquest, irrespective of what we'd said, irrespective of what Oliver had said, she was going to give that medication anyway.
I just wanted to make just say a couple of simple words at the end. we'll come to thank Paula in a couple of moments. It's inspirational to listen to someone who's been through such a horrendous experience and be able to talk about it dispassionately and reflectively and try and get the learnings across, particularly to medics, but to every one of us who deals with patients. And I think when you look at someone like this, you have to always challenge yourself to remember that what you see with your eyes is not necessarily correct. You know, so your ability to communicate with an individual, you see like that, the assumption you make about your ability that he can understand and take in, deal with it and respond, you have to challenge yourself all the time. So the whole concept of making reasonable adjustments in many senses comes down to the chat we had earlier on. I'm talking about the students in the room. We spoke earlier on in the week about the ability to get to know your patient, and it is all about understanding them, spending time with them, communicating with them. And the more you do that, the better your chances. You are in that process making reasonable adjustments, and you are in that process avoiding and reducing the risk of things escalating when they shouldn't. So there are loads of lessons for even a hospital like this. There are lessons about passports. In Oliver's case, a passport existed but was ignored. And we should ask ourselves, does that happen to patients who come in here? And when our patients go out to general hospitals, do they go with passports? And do our people remind clinicians about what's in passports? It's very important to communicate the stories out and receive them in. So I think there are simple lessons for us apart from wanting to back the campaign to introduce training across the organisations. The second point I'd make to the people in the room who could potentially influence the way in which data is collected, it would be incredibly helpful in 10 years' time that data is collected about LD patients and autistic patients separately. The last thing I want to say is that we spent time with Paula earlier on. It's an inspirational story, but it's inspirational to see someone who has the courage and the tenacity to keep going and keep going against the odds and keep pushing and pushing. She's found plenty of people who believe but are stuck in a system, and we're all part of a system and part of our obligations to try and make our system work. So I really want to thank Paula for the time, for coming, for the talk. Encourage her to continue on the journey. Those of you who don't support the campaign for Oliver, you'll find it on Twitter, you'll find it on Facebook. Those of you who haven't signed the petition in Parliament, it's very easy to do, get the 50,000 up. And those of you who have ideas about what should be in the compulsory training, do continue to contribute in some form or other. And lastly, I'd like to thank Katie and Dr. Barnett for their effort in organising all of this. So thanks very much, everyone. I hope you found it useful.